our program for today, which is one kind of dear to my heart, and it's going to be about balancing AO principles in calcaneus fractures, which I don't understand exactly what they mean by that, because in my mind, both types of procedure you're going to hear about will be internal fixation of the calcaneus, but by different techniques. This, of course, is going to be primarily the methods most commonly used by Dr. Bernurska and Dr. Sanjorzen. The thing you have to remember, though, as you're hearing this morning, these are the two of the guys who were the first people to really start doing calcaneal fracture repair, and they started almost as early or earlier than anybody did in the world, really, and have had a volume and an experience that is unmatched. And so you're going to hear the absolute epitome of what can be done with these two techniques and not what is done in the general community around the world. And so if you think you can match this right away without getting into it a bit and getting some skills, you have to keep that in mind. So Dr. Alton has agreed to moderate this and start us off. And Tim, are you ready to go? Thank you.
My name is Tim Alton. I appreciate the opportunity to share the stage with some real giants in the field. And today we'll be talking about calcaneus fractures. I'll start with a discussion of some of the important anatomy of the calcaneus. We'll then delve into some of the characteristics of the fractures and then set the stage for management issues. Dr. Bernurska will be talking about the extensile lateral open approach, and Dr. Sanjorzen will talk about the mini open approach, and then we've got 3 cases to highlight some of the issues that are raised in our talk today. In 1916, Cotton said, "The man who breaks his heel bone is done." And this highlights some of the early frustrations with closed management of calcaneal fractures. Kahn in 1935 reinforced this by saying, "Calcaneus fractures are serious and debilitating injuries in which the end result continues to be incredibly bad." Some of the early results of operative management were less than ideal. It was very challenging for people to start to put these back together, and led McLaughlin in 1942 to say, "Operative treatment of calcaneus fractures is like nailing a custard pie to the wall." So as we developed advanced imaging and began to really appreciate the complexity of the calcaneus and its anatomy and some of these fracture fragments, and really paid attention to managing the soft tissues appropriately, operative fixation of these fractures became more commonplace. We'll begin by discussing 5 important aspects of the anatomy of the calcaneus. We'll talk about the 3 superior articular facets, which make up the subtalar joint. We'll talk about the sustentacular piece, the medial and lateral walls, and the distal calcaneal cuboid joint. These are 4 different projections of the calcaneus. I've highlighted here the blue posterior facet, which is the largest of the facets. The red corresponds with the middle facet, and the green is the anterior facet. The anterior and middle facets are commonly contiguous anatomically and actually support more force for surface area than the posterior facet. The yellow area here represents the sustentacular piece, which is an important anatomic aspect because it's very dense bone and is commonly a site for anchoring fixation when putting these fractures back together. The medial wall of the calcaneus, is highlighted here in yellow, supports the facets underneath of the sustentacular piece and is in close proximity to the neurovascular structures on the medial side. With displacement, you can get injury to these neurovascular structures and even some of the tendons that run on the medial side of the foot and ankle. On the lateral side, you can appreciate the lateral wall of the calcaneus is a rather flat structure. It's a common site for anchoring fixation constructs, low-profile plates and screws. And I'd like to draw your attention to the soft tissue envelope over the lateral side of the calcaneus, which is thin and needs to be managed very carefully to prevent wound healing and deep infections postoperatively. And then finally, the anterior calcaneal cuboid articulation is highlighted in orange, and while a bit more forgiving than the other joints, it's important to get this anatomically reduced as it is an articular surface. When looking at calcaneus fractures and evaluating these injuries, it's important to understand Bowler's angle and the critical angle of Gissane. The critical angle of Gissane is normally 120 to 145 degrees, and radiographically, it's a projection of the dense bone of the posterior facet connected to radiographic projection of the dense bone of the anterior and middle facets represented by these red lines here. And what this gives you an appreciation for is the three-dimensional orientation of the anterior, middle, and posterior facets to one another. And that's essential in managing calcaneus fractures and putting these fractures back together because the subtalar joint is an integral part of the biomechanics of the foot and ankle and gait, with inversion and eversion being important for locking and unlocking the subtalar joint, locking and unlocking the midfoot. Bowler's angle is formed by a line drawn from the superior aspect of the anterior process of the calcaneus to the superior aspect of the posterior facet, and a line intersects that from the tuberosity to the superior aspect of the posterior facet. A normal angle is 25 to 40 degrees, and you see that with calcaneus fractures, when that posterior facet is displaced inferiorly, Bowler's angle becomes more acute with that displacement. Calcaneal dimensions, including height, width, and length, are also important. The height of the calcaneus is simply the superior to inferior distance of the bone. You can see on this x-ray of an injured calcaneus that the height is significantly decreased as the talus is driven inferiorly into the body of the calcaneus, displacing that posterior facet. The width of the calcaneus is simply the medial to lateral distance of the bone, and this is an axial projection of an uninjured calcaneus representing a normal width of the heel. You can also see on this image that the lateral wall is relatively flat and reduced, and the posterior facet can also be seen. And finally, the horizontal length of the calcaneus is important, and this can be evaluated on a sagittal projection of the calcaneus. It's simply the anterior to posterior distance. You can see that with this calcaneus fracture, the calcaneus is significantly shortened. This is important biomechanically because by shortening the calcaneus, you're essentially shortening the lateral column, which abducts the foot, uncovers the talar head, and leads to lateral peritalar subluxation and overstress of the posterior tibial tendon. Now delving into fractures of the calcaneus a bit more, we'll first look at the mechanism of injury. These are axial loading injuries in which the calcaneus is driven down into the anatomic equivalent of the angle of Gissane, leading to fractures that commonly present in this area. These are called the primary fracture lines. Secondary fracture lines can also propagate out into the anterior medial fragment of the calcaneus in a stellate pattern. This primary fracture line, represented in red, divides the calcaneus into two primary pieces, an anterior medial piece and a posterior lateral piece. It involves various aspects of that posterior facet. You also get comminution that extends posteriorly, and that's responsible for either joint depression or tongue-type fractures that we commonly hear about. In the top right image, you can see a model representing a joint depression fracture. The primary fracture line is represented with that red line. The secondary posterior fracture line exits in between the posterior facet and the tuberosity, separating these two anatomic structures. So that posterior facet is more or less a free piece and can be driven inferiorly. This is a sagittal CT scan representing a joint depression injury with the primary and secondary fracture lines being seen there, and the posterior facet's been driven inferiorly. This contrasts to tongue-type injuries, which are seen on the lower right image, in which that posterior fracture line exits lower down on the tuberosity of the calcaneus, and the posterior facet and the tuberosity actually remain in continuity with one another, as seen in this sagittal image, primary and secondary fracture lines. As the talus is driven down into the calcaneus, various manifestations of this energy and displacement occur, the first of which is posterior facet comminution. You get varying levels of facet comminution based on the amount of energy that's transferred from the talus into the calcaneus. These are three axial representations of varying degrees of posterior facet comminution. Subfibular impingement is an important concept and something to be evaluated as the talus is driven down into the calcaneus. That lateral piece of calcaneus can be displaced into the inferior aspect of the fibula. In this case, it actually fractured the fibula, but the perineal tendons are in that area. They can become pinched and injured, and if not reduced, patients then bear weight through this displaced lateral piece through their distal fibula, which hurts as it's not intended for that. Heel widening results from displacement of the calcaneus. You can see the green line here represents a relatively normal heel width, whereas the red shows that the fractures have not been reduced. You've got subfibular impingement and a widened heel. A final concept that I'd like to discuss is the talar attitude. and how the shape or how the position of the talus changes when the calcaneus is not appropriately reduced. The upper image here is a normal foot, whereas the lower image is a fracture that's not been appropriately reduced. I'd like to point out that Gissane's angle is greater than 145 degrees here, and the facets have not been reduced into their normal anatomic location. The Bowler's angle is very acute, less than 25 degrees. The posterior facet's been driven inferiorly into the body of the calcaneus, and the height has been lost. And then finally, as a result of these, the talus takes a more horizontal position relative to the normal foot. This leads to impingement between the talus and the distal tibia. It alters the biomechanics of the subtalar joint and the talonavicular joint. Now, in looking at management issues, we've been able to identify some factors that predict how patients are going to do with these injuries. Certain factors for which patients do better are a younger age, simple fracture patterns with less comminution, having an initial Bowler's angle between 0 and 14 degrees, obtaining and maintaining an accurate articular reduction, and maintaining subtalar motion. Factors that predict worse outcomes can be divided into patient factors and anatomic factors. The patient factors are smoking, diabetes, and peripheral vascular disease. Anatomic factors include bilateral injuries, open injuries, injuries that have significant comminution and loss of cartilage, and patients who become stiff or have significant edema after their injuries or their interventions. In 2002, Dr. Beret and his colleagues, you guys will recognize most of these names, described treatment options for calcaneus fractures and said that virtually every aspect of management of complex calcaneal fractures is controversial. And over a decade later, I would say that that statement is still very true. There are three primary treatment options. Those include closed management with or without a reduction, an extensile lateral approach, or a mini open approach. Salvage procedures would include a primary fusion, but we'll be discussing these three today. When looking first at the closed management techniques, this is based on the fact that patients are made non-weight bearing, they're splinted, and then they begin early range of motion. This has been evaluated in the literature, and 2-decade follow-up of 84 fractures showed that these patients get arthritis of their subtalar joint and their ankle joint 90 and 100%. So while it's cheaper, there are less soft tissue complications because you're not making any incision in the skin. We do see higher rates of arthritis in these patients. The extensile lateral approach allows you to get perfect reduction of the articular facets, but you've got to be very mindful of these soft tissues so you don't get wound healing problems and deep infections. 47 cases were followed 10 years, and they found that 40% of these cases actually had excellent results, and the reduction quality correlated with their outcomes. So it leads to the question, is operative management better than non-operative management? And there have actually been 2 randomized controlled trials to look at this, and interestingly, neither showed very striking significant differences. In fact, this paper looking at 471 fractures followed from 2 to 8 years found no appreciable difference in operative versus non-operative management. The other randomized controlled trial looking at 82 fractures with up to 12 years follow-up, at 1 year, once again, no appreciable difference. But it's important when looking at the literature to look at how they analyzed this data and what their outcome measures were. They used the VAS, the SF36, and the AOFAS, and these outcome measures have problems when evaluating calcaneal fractures. Specifically, the SF36 is non-responsive and the AOFAS is non-validated for calcaneus fractures. But when looking at this RCT, at the 8 to 12 year follow-up, they did find with the surgical group that there were lower rates of post-traumatic arthritis and some trends in improvement in the VAS scores and higher rates of complications with open surgery. And that brings us to our third technique, which is the mini open, which is thought by some to be a hybrid between the 2 other techniques in that you get a better reduction than closed management, but it's less of an assault to the soft tissues. And one paper looked at the minimally invasive technique versus an extensile lateral approach, and they found more complications in secondary surgeries with the open approach, no significant differences in the Bowler's angle or the angle of Gissane, and similar clinical results. So with that context, I'll hand it over to Dr. Benershka, who will be talking about the extensile lateral approach.
Good morning. I have to really always begin a discussion of this topic with a recognition of two of my mentors. Fortunately, one of them is here in this room. Ted Hansen really was one of the ones that spurred Bruce and I to really explore this area. And the person on the left is Emile Letournel, who actually visited us in 1985 and had an interest in calcaneal fractures and actually showed us how he managed them at Harborview, and that's what spurred us on with our early investigation of this problem. The rationale for the open treatment of calcaneal fractures is essentially one, to correct all the deformities that Tim alluded to essentially reestablish the morphology of the bone, and that is the shortening, the articular incongruity, and in hopes that you would get optimal foot function. The tuberosity position of the foot is critical in that plantar pressure is pivotal in normal gait, with whether it be running or walking, and that is essentially what initially is hitting the ground or the floorboard in a car wreck. The current management schema that we've done, really based on Bruce's study on the understanding that even 2 millimeters of displacement will cause an irrevocable change in subtalar biomechanics, significant varus deformities, and essentially a significant loss of height, especially in an injury where you're thinking about conservative treatment, but the height is significantly changed. And the question is, how do you measure that? Here's an example of an injury, a tongue-type lesion, where you see that there's marked depression of the articular surface, but you also see the plantar tuberosity of this heel has been imploded. And when you compare that to the normal side, that actually accomplishes a significant change in the shape of the foot on this sagittal view. We've learned early on that timing was critical, and if you wait long enough, even the more complex soft tissue envelopes will resolve. And this is just an example of a 70-year-old man who we ultimately treated, but you can see it took 3 weeks for him to resolve his soft tissue envelope. Open fractures has always been a bugaboo with respect to the management, because the concern of infection. And since most of these injuries are medially open wounds, we've identified that perhaps there's a better way of managing them than when we originally performed this surgery, because we didn't really adequately reestablish the shape of the bone and tried to manage the medial wound just with dressing changes. And you can see the substantial displacement of this particular injury. So we've essentially tried to avert some of the soft tissue problems on the medial side by realigning the foot, and this is just a rendition of how that would occur to, from the medial side, reestablish the shape of the foot while you're waiting for the soft tissues to recover, so that when you go later to do any kind of treatment, you will have less difficulties with the lateral soft tissues. This is just an example of that same patient where the soft tissue conditions improved, the lateral blistering resolved, and he underwent an extensile approach later. We look at the 2D CT to ascertain, for when you're doing open treatment, the size of the sustentacular fragment, the size of this area where we're going to anchor our fixation. That's pivotal in terms of the management of this particular problem, because you need something that you can anchor and compress to. And really, when I was given the charge of this in 1985, I approached it like another one of my mentors, who is Tom Rudy, who had, with his mentor, come up with an algorithm for the management of articular fractures, and that goes along with the principles that we mentioned earlier. That is to do an anatomic reduction, in this case of the shape, to provide rigid fixation to allow early functional after treatment. And you see that most of these involved bone grafting defects because of the articular surface impactions that were present. And essentially, we evolved to an extensile approach that you can sort of see on this artist rendition from Kate Sweeney, that shows essentially all of the architecture on the lateral side of the foot can be managed by an extensile approach. And the one caveat is that there is an indirect reduction of the sustentacular component of this injury to the medial wall of the tuberosity. But that indirect reduction actually facilitates more rapid healing, because you don't disturb the blood supply on the medial side. This involves essentially positioning the patient in the lateral position, because we try to do this supine. It's quite discouraging to try to do this in the supine position, so we've evolved to doing it in the lateral position, and we have special pillows and apparatus to essentially keep the patient comfortable, including their upper arm, so that they essentially can lie on their side comfortably while the surgery procedure is doing on the lateral position. The extensile approach is essentially a J or an L, and it's based on whether you're doing a right or a left heel, and you can see that essentially this is very different from what we initially had embarked on that Emil Chanel talked about. And this is essentially was the Coker approach, which was done prior to 1985. And you can see the blue line there. That was the surgical incision. And we did this because Emil showed us that this is the way he was managing them. And unfortunately, we had the discouraging view of a number of structures we didn't really want to see, the sural nerve and the perineal tendons, many of which would granulate in at the time of closure of the wounds because the soft tissue envelope was very precarious in this area. So we evolved to this sort of more extensile approach where you are doing a J or an L, where you're doing a periosteocutaneous elevation of all of the structures on the lateral side, including the perineal tendon sheath. And essentially the order of reduction is, once again, this sustentacular fragment anchoring the angle of Guisan, which is here, and the anterior process to the sustentaculum, and then working our way posteriorly to the posterior facet. This requires a headlight. And for us to see into the wound, to see the articular surface reduction, you need to be able to see into the void that you're essentially looking into in the depths of the foot. And so this requires some sort of light to see in because you cannot do this by indirect means. The final thing after the articular surface has been reestablished, then the final path is, as mentioned before, the realignment of the tuberosity so its orientation is appropriately shifted so that you can get a better position of the heel on the floor. And this is just an example of an under-reduced where the medial wall has not been reduced yet, and that same fracture, when it's translated appropriately, you reestablish the tuberosity position. We bone graft the defects in the early 80s, or 85 to 87. We used only autogenous bone, so everybody got an autogenous iliac crest bone graft. That's evolved to using largely allograft since 1988. Implant evolution has gotten better. We've gotten higher energy injuries, so we have to work on getting implants that are stronger, and that's because the joint has to be supported for these more high energy injuries. And we're using lower profile implants that primarily are stiffer in this area so that they can control the forces of the talus as the patient walks and can maintain the position of the tuberosity. The lateral joint depression component of an injury that is present is always avascular, and this is an example of that lateral articular segment. Look from the lateral view, and this is the medial cancellous surface. That is essentially what has to be fit in here, and this is an example of a true osteochondral autograft, where the posterior facet has been anchored after the anterior process has been reduced. You see it keyed in here, but you can also identify that it has no blood supply. By essentially fixing the alignment of the foot and reducing the joint surfaces, you then have to provide medial to lateral compression, and that's afforded by the plate, so that when you actually compress this fracture, as Tom Rudy did with pilon fractures, we compress enough to restore the width of the heel that screws that you initially think are appropriately of the right length are actually too long and have to be shortened. Here's just an example of a couple of cases. Here's a joint depression injury. You can see the classic lateralization of the heel with slight varus, the translation that you see compared to where the medial wall is, the articular surface depression. This is the fracture lines that Tim alluded to, the anterolateral to posteromedial fracture line, which is the primary fracture line, the secondary fracture line here, which has to be reassembled, and we would start with this fragment to the constant fragment, which is the sustentacular fragment, and then work our way back. So this is the intraoperative view of the articular surface restored with the tuberosity positioning, not compression yet, and then this is now after the plate has been placed to compress the morphology. There are osseous defects that invite collapse, and you can imagine with some of the more dramatic injuries such as this one. This was an open injury. You see it took almost a month for him to heal to this point, but it's still not healed. This was prior to our use of the external fixator, and initially you can see that there's a daunting CT scan about how you're going to manage this, but essentially if you approach it the way we were discussing earlier, this was the amount of bone void that was missing. This was bone grafted actually with just cancellous bone graft. That's at 6 weeks, and here he is at a year, and slight settling of his morphology, but a reasonable maintenance of the alignment of his foot. When you close the wound, you have to do a periosteocutaneous flap. Once again, the old Burler approach, which was here, had a very thin soft tissue envelope. Here you have a much more robust periosteocutaneous layer that you can use, and then all of these sutures are placed to essentially help you reestablish the flap position, which is now put on stretch because you've restored the shape of the heel. The closure of the skin should theoretically be with as little tension as possible because that's the one we're most concerned about, getting early sealing of the wound. They're all splinted and they start range of motion when their incision is sealed, and routinely for the joint depression injuries or for the injuries that we do it with an extensile approach, they're non-wavering for approximately 12 weeks. This is just an example of a patient that essentially we encourage them to move as much as they possibly can. This is a joint depression injury about 6 or 7 weeks after her surgery, and essentially we try to get her to do as much motion of her foot as she can while she's waiting to walk. And it's frustrating for these patients because they think they can walk because their foot doesn't hurt and their foot moves. The bad, concerning problems that we have are the smoker, the diabetic, and the non-compliant patients. We identified that in our study, and those patients still will come to you, and the question is how you're going to manage them. This is just an example of all 3 of those, and you can imagine if we'd left this alone, it would have been a daunting reconstructive process. I elected to try to manage it, but was unable to manage this without having some intermittent wound drainage here, which necessitated hard removal, but we were able to maintain the position of his foot. And that's an easier problem to deal with than trying to manage this conservatively and then a later procedure. So what is a surgical emergency? Well, we've talked about the open fracture. That's quite obvious. That needs initial management. But we've also identified a number of patients that have been sent to us with skin at risk, and that is where the cutaneous envelope, principally the posterior envelope, has been put at risk. The skin is essentially white here. If it's not managed acutely, will become black because it's avascular, and that necessitates some immediate management. And this was written up by Mike Gardner, who alluded to the importance of reduction of that displacement. This is what happens if you don't do that, and you can see this is a relatively elementary tongue variant injury, and you can see essentially the tuberosity is trying to erode its way through the skin. We have new injury patterns that really defy description. You can't even classify them. This is an example of what you see in a head-on collision on the freeway. This is a right foot that was broken by the impact, and the left foot was also broken, but this is just by way of an examination of the shape of the normal foot compared to the injured foot. We literally just tried to reestablish the morphology with this frame. The reconstruction here you see is acutely was done about 3.5 weeks later. We saw him at a year and at 7 years, and it's not perfect, but he manages to walk and he doesn't have any pain, so we've accomplished what we set out to do. We did look at the outcomes of extensile approaches, and we found that if you look closely at all of these patients managed exactly the same with respect to the extensile approach, that we could get reasonable soft tissue management success. There were some issues with wound healing difficulties. All those patients were managed only by hard removal, did not require any other sort of management such as a free tissue transfer. So in summary, really, there is a possibility of doing an anatomic reduction. The risk of infection is reasonably low. It's not 0 or 1%. It's a bit more than that. But the idea of doing complete morphologic reconstruction makes sense. I have to say, I think it's worth the effort given when you see the patients coming back compared to what I saw when I was in training, which was never seeing one of these treated. In '85, once again, when we started doing this, about 30% of the referrals to Dr. Hansen's foot reconstruction clinic were calcaneal post-traumatic reconstruction. That is patients that were not treated, that were treated conservatively and needed an operation of varying types to try to get them to walk, but none of them were happy. In 2014, I would say nearly all of the fractures that we see at our institution are treated. Most of these are extensile or the mini incision based on the particular aspects of the injury. All the reconstructions, which are fortunately relatively rare now, are done with this extensile approach. That being said, sadly, 2 days ago, this is a patient that came to my clinic. This is a 25-year-old man who had a fall off of scaffolding at a construction site in Oregon. And he, as you can see here, he was never treated. He now is 2 years after his injury, and he's in a wheelchair, has not been able to walk. His spine was treated appropriately, but this is his reconstruction attempt that we're going to try to have to manage, which will be daunting. And finally, a sobering future for the residents and those individuals that will be managing trauma. If you look at what is going to happen worldwide, if you look in 1990, the sequelae of road traffic accidents as measured by the DALY scale, which is the Disability Adjusted Life Year scale, it will go from number 9 to number 3 in the next 6 years. So it'll be a significant problem that society has to contend with. Thanks. We're going to go on now. Bruce is going to talk about the mini incision approach.
So we'll go quickly. I have no commercial conflicts of interest to disclose. So we have only observational evidence to support open treatment and limited understanding of what patients mean. So Tim talked about the fact that we have 2 large prospective trials that have shown no difference in outcome between 2 groups, non-operative and operative. And yet both of those trials have shown that in the non-operative group, the incidence of post-traumatic arthritis is between 4 and 6 times as high. So what that tells us is that the study quality wasn't very good and the outcome measures used were not responsive to the treatment plan that we were doing. Nonetheless, the data has gone from when Dr. Bernershka and I were taking our boards, it was a risk to have open treatment of a calcaneus fracture on your patient list because it was considered a little bit out there. And then just a couple of years ago, I had to defend 2 doctors who chose to treat a patient non-operatively and were being sued for not doing surgery on a calcaneus fracture. So it just shows how public perception changes way out of line with the data that we have to drive decision making. So the literature does support the idea that open reduction provides better outcome for patients if you take out the ones that have no problems or complications with their soft tissues. Small incision treatment makes a lot of sense. It's defined as any variety of approaches that doesn't use the extensile approach as described by Dr. Bernershka. It was initially used to describe tiny little incisions, but now it's been expanded to the point where people are now making those old Palmer or Coker incisions and calling them small incisions, just like we were back in the late 80s. So small incision is good because it's the number 1 predictor of poor outcomes is stiffness, and you get stiffness from having a big flap, and you get stiffness from having a splint, and you get none of those things when you have a small incision approach. The biggest complication from treatment of calcaneus fractures is wound healing complications. And I know that Dr. Bernershka just reported a 1.6% wound healing rate, but that is way different than most of the literature shows. And because even in our institution, small incision results in better outcomes. So this concept's been around for 15 years. This is one of Paul Tornetta's papers. I've actually been doing this for about 20 years, and I'll show you that patient here in a moment. The possible treatment outcomes that you get from non-operative care are widened heel, horizontal talus, fibular impingement, perineal tendon subluxation, and stiffness, and all of those can be managed with a soft tissue, with a small incision technique. And you get soft tissue, compromised soft tissue, which is the key element for doing the small incision technique. So we've kind of covered why to do it. I'm sorry, we'll also go over when, who, and how very briefly. So why do we do it? Patients like the idea. It reduces the number 1 cause of poor outcome. It shortens the length of stay and reduces cost significantly. And it, in our estimate, reduces healing time as well. So when do you do it? When implies 2 different questions. So what fracture pattern is good? We know that tongue-type fracture patterns with posterior facet intact, that was our initial target group for small incision technique. Those with limited anterior process comminution, those with soft tissues that are incompatible, those with conflicting injuries. So if you have a tibial plafond and a talus fracture, those are higher priority injuries, and we don't want to take priority away from those higher injuries to make an extensile approach. And patients whose outcome are known to be poor. In our own institution, we studied open treatment with extensile approach and showed that those who had a lot of anterior comminution had a poorer outcome than those who did not. So that group also fits in. So who should do it? The same people who do open treatment of calcaneus fractures. It is not that simple to do. You have to understand the fracture patterns. So you need a good 3D understanding of the fracture patterns. You need someone who has a C-arm who knows how to get into position. And you have to have done a sufficient number of calcaneus fractures by the open technique to really understand what the parts are. So how is it done? It's done through small incisions, about half a centimeter in length. Small elevators introduced to move the pieces around. Fracture fragments reduced with a Gassane spike or some other technique, and performed under fluoroscopic guidance. There are no plates used, no bone grafts used. The C-arm is brought in from the end of the table. So here is the foot of the table. The patient's head would be up here, and the C-arm can rotate up to get a lateral view, as you see here, or a Broden's view. And it can flip down so that the transmitter is at the end of the table, or the transmitter is at one end and the receiver is at the other end, so you can get the axial view, so you can get a good view of the sustentaculum that Tim talked about, the posterior facet, the middle facet, and the medial wall. So this is a kind of typical fracture pattern with joint depression, or with a tongue component, but with a very significantly depressed posterior facet. And you place the Schanz pin in, elevate it up, and then provide your fixation across the anterior facet cross the fracture line. And this is the index patient that I talked about from 1994. He had this fairly simple tongue-type fracture pattern sustained in a fall at work. He was a laborer, and I had very difficult time getting through to him to make him understand that he had to stop smoking. He wouldn't be able to walk on it. It was clear he was not going to be compliant with the postoperative management we were talking about. He had this comminution of the anterior process, but wasn't dramatic. He had a largely intact posterior facet on the tongue fragment, and he had the pressure on the posterior skin that Dr. Benershka just alluded to a moment ago. So he was treated with a Gassane spike. We brought the tongue piece up, so from the depressed position into neutral position. This is the sustentacular screw. These other three screws are crossing the fracture line. This is the axial view showing an incomplete reduction. And I mentioned that this is the index patient. I chose this technique because I didn't think he would listen. He was one of those people who made the upper half of the class possible. His cognitive limitations were apparent in the discussion. And when he came back at 2 weeks to get his sutures out, I was sitting and taking his sutures out, and I looked around the room and I saw that he had 2 shoes, no splint, and no crutches. And I said, "Where are your crutches?" And he said, "I think they're in my closet." And I said, "Your closet at home?" And he said, "Yes." And I said, "How'd you get here?" He said, "I took the bus." It turns out he had walked 6 blocks to the bus. He had gotten on the bus, taken it 3 blocks from the clinic, come to clinic. And I said, "You know you're not supposed to be walking on this." He said, "I didn't walk on it, I walked on my toes." So, of course, he multiplied the lever arm dramatically to pull that tongue fragment back to where it was. We took him back to x-ray, and it had not displaced at all with just these 5 screws. So that was my index telling me that this technique had opportunity, that this guy could be full weight bearing in 13 days post-op without any destruction of his injury. And this just, so I started doing a little bit more of them after that. So this is the technique. It can be applied to a variety of different constructs. The red line represents the Gassane spike. And I'm sorry that's not showing up very well, but the anterior process has to be put together first with this screw, and that allows you to get these other crossing screws across the primary fracture line. So it can be used in a variety of conditions. You can get a fairly good reduction of that medial wall. You want to get a crossing screw into the sustentaculum tali, and you get that medial wall reduced back to normal. As you get a little more experience, this clearly would not be a fracture pattern that would be usually used for a limited approach, but this is a patient with a back injury, had a burst fracture. He had bilateral calcaneus fracture. He was actually a medical student here who had broken both of his heels. We wanted to get something that would heal fast with lower extremity swelling. This is what he looked like pre-op, and this is what he looked like post-op. Almost reduced, not completely perfect, but his alignment, his contours, his height was restored, and he healed quickly. These are what the incisions look like. So here, this is the incision from the Gassane spike. The rest of these are for screws to go in, and this one is where the AO elevator is introduced to elevate the front of the posterior facet. They can be used for joint depression injuries too. This is one of Bob Dunbar's patients he was on call, brought this patient in, washed him out, got a nice fixator, got an excellent reduction just with the fixator, and this got most of the pieces back except for the fracture in the middle facet, which we were then able to elevate at the time of insertion of the screws and wires. This is a 78-year-old patient with a poor soft tissue envelope that was open medially. This is her after the operation. This is her at 1 year back to relatively normal function with pretty good movement. We can also use it for those with a known poor prognosis. We know that these die punch injuries anteriorly, where you've taken a big chunk out of the front of the posterior facet and the back half of the middle facet, these do not do well with open treatment. They become stiff. Here's that die punch injury. You could see it starting at the front and moving back into a fairly comminuted extension into both the middle and the posterior facet. So in this example, the posterior facet is elevated. This tuberosity piece is pushed out of the way. The die punch is pushed up with the back end of a Penfield elevator. That allows everything to line up along the posterior and the middle facet. And then screws cross that fracture line. You can see the same thing on the axial view with the reduction in a stepwise fashion. Here's the patient at the end of the operation with a near but not completely anatomic reduction. It can also be used in a tongue type with comminution. This does not fit into our initial fracture pattern either. It's almost a combined joint depression and tongue with a blowout of the medial wall. And this is the axial view showing that the joint was stepped off more than a centimeter. The anterior process is highly comminuted, one that we know would not have a good outcome with the traditional approach. Here are the sagittal reconstructions, again showing the posterior facet quite depressed and comminution in the anterior process. And as you take the Chance pin, introduce it into the tuber, bring that up, push up the front of the posterior facet until the posterior and the middle facets are anatomic. Hold that in line, fix the anterior process, place screws across the primary fracture line. And here's the patient at the end with a nearly anatomic restoration and no incisions. Here's the axial view of that same patient showing that we have not completely reduced the medial wall, but we have the posterior facet and otherwise the alignment is good. Here's the patient at 6 weeks post-op, and here's the patient fully restored, normal weight-bearing activities at 10 weeks. The comminution along the medial wall has now healed. And finally, this is an elderly demented patient with bilateral calcaneus fractures that we would have loved to have treated closed, but he had skin at risk, and his family said the only thing he can do now that he's so demented is to walk. So we took these relatively comminuted injuries, reduced. So here's the right side with a lot of anterior process comminution, tuber involved, brought it up, reduced the posterior facet, reduced the tuber, held those with K-wires and cannulated screws. Here's the axial view of the same. You can see that the posterior facet is completely restored. And here's the left side that was even more comminuted, followed the same pathway to reconstruction, restored posterior middle facet, completely nearly anatomic. The patient, of course, began walking before we told him to, but he managed to heal in this position, and this is him when I saw him back in clinic with no pain and virtually normal motion. This is a video of a patient at 3 weeks. You can see his incision. He's got nearly normal range of motion. So is there data to support this? We actually did a trial at our own place comparing isolated calcaneal fractures of a tongue type, and briefly, the patients who had the small incision stayed in the hospital about a third of the time. They began unrestricted weight bearing in less than half the time. Their pain scale was lower throughout the entire course of the postoperative time. Their complication rate was unchanged in the two groups. At 6 weeks, they had better outcome scores. At 3 months, they had better outcome scores. At 6 months, they had better outcome scores. And at 12 months, they had better outcome scores. So all along, less expensive, faster healing, better outcomes, and better motion. So these are reasons to do it. I'm not going to tell you that it's good for all calcaneus fractures, but it should certainly be part of the armamentarium. And sometimes it doesn't go well. This is someone who came to one of our conferences, saw these x-rays, but had no experience doing calcaneus fractures. This is the result. I got it at 6 weeks with the screws not in the fracture, not reduced, and a much more difficult time restoring this back to something that the patient could walk on. So it's not idiot-proof. Most of the papers addressing small incision techniques have no comparative cohort. They've selected out the relatively easy patients to study, so the data isn't very good, but at least in our institution, we compared them with experienced surgeons, similar calcaneus fracture patterns, and showed that this technique works. But don't forget that a lot of calcaneus fractures can be treated non-operatively, and you have to keep this in mind when you're looking at these non-operative or these comparative studies of the small incision technique with the simple fracture patterns. These are the patients that don't need an operation at all, and they're not a worthy cohort for comparative purposes. So this technique's worth knowing about. It has a lot of advantages, but it's not perfect, and thank you for your attention.
Dr. Benerska, if you'd join us, we'll just briefly review a couple of cases, and I'd like to have you guys take a look at the injury films and talk about sort of your thoughts on management and things that you guys consider. So the first case is a 24-year-old gentleman was a high-speed motor vehicle collision, a closed left calcaneus fracture, otherwise healthy patient, doesn't smoke, no real medical problems. So here's the injury plane films. And then we'll just click through some CT scans. These are sagittal shots, the coronals, and the axial. So maybe Dr. Sanjorzen, you could start by looking at the films and telling us what you think.
Let's just go back. So we start with the lateral view because that gives us the measure of Bowler's angle that Tim alluded to. It's a fairly flat Bowler's angle. If you draw the line here and here, it's probably in that range of 5 to 10 degrees. It looks on the plain film like the posterior facet is largely an intact piece. The middle facet does not appear to be terribly displaced. You can see, however, that there's comminution extending into the anterior process, so there probably is more that you can't see. The medial wall is buckled. It's about a centimeter lateralized. That puts it on the border of whether it needs an operative approach or could be managed non-operatively. The CT scan supports that the posterior facet is in a large piece as you scroll through it. And the middle facet is posterior facet, middle facet not too terribly badly displaced. The comminution looks like it's more lateral. And on the coronal cuts, there's a pretty significant step off that probably isn't ideally treated by non-operative means. There's probably 8 to 9 millimeters of step off there. And it's laterally displaced so that there's going to be some impingement into the subfibular space. And I think Dr. Bernerska would both agree that this probably should not be left non-operatively managed. Any comments on that?
I think the main question is always, and my feeling is morphologically, if you can restore the shape of the foot, and that in many of the tongue variant injuries, if the anterior process is not too common or has not been superiorly translated, that you can, essentially when we do this open, it's a percutaneous manipulation of the tongue variant injury with a Shan's pen as well. The difference being that when Bruce is doing it, he's manipulating that and then affixing it with percutaneous screws. The whole rationale for open versus closed as a management is to establish as best you can the morphology of the foot and however you can execute that. And I think that was well illustrated by Bruce's talk, and you can just sort of see the difference with open treatment is essentially a management primarily of more comminuted anterior process lesions, which unfortunately ends up being more common with the nature of motor vehicular collisions that we see today.
This patient ended up in Dr. Sanjorzen's hands and got the minimally invasive technique.
So Shan's pen was placed. The AO elevator is used to push upward on the front as the Shan's pen is used to rotate until this piece is down. You can see that this patient started out in a little bit cavus configuration, so you have to tuck this top of the tuber in and then place fixation across that fracture line, which is going in this angle. And the anterior process had to be secured so that this screw would have something to bite into. Medial wall is restored. And it's not perfect. Their anterior process piece is still up a little bit, but the facets are pretty good. The height is normal. And at 6 weeks, it's largely healed, and at 10 weeks, back to normal.
Our second case is a 51-year-old lady who fell off of a balcony, has a closed right calcaneus fracture, a distal radius fracture, some rib fractures. She's hypertensive and has hypothyroid. She doesn't smoke, and she works as a manager at a Weyerhaeuser Lumber Company. Dr. Bernerska, maybe you could scroll your way through these films and give us your thoughts.
So this is an example of a joint depression injury, and you can see the primary fracture line, which, as we talked about earlier, goes from anterolateral to posteromedial. That's separated the posterior facet fragment, and here you see the transverse fracture line that goes into the middle facet, which is caused by this axial loading. The tuberosity has been driven somewhat superiorly. If you go to, this is another view that kind of shows the most significant impaction is really at the tuberosity posterior facet interval and not so much in the front. You see this area is relatively spared. The medial wall is shifted, as you characteristically see, with a bulge here related to the posterior facet being depressed. This is just a CT scan. Shows you that really it's the entire posterior facet that you articulate with is essentially with the talus. There is a blowout of the lateral wall, but the major articular surface is essentially one fragment. This just, I think, is scrolling through that. And here you see that this depressed area, this is rotated down slightly. You can see where the articular surface probably should originate and the tuberosity where it has to come down. So this is really her major deformity is actually in the back. I think here, going through that. Do you want to?
Yeah, so would you, what's your plan then for this patient? Would you take it to the operating room and do an open approach, or any other
I think
thoughts?
a lot of the discussion, as Dr. Hansen mentioned, is really based on an understanding of what the patient's intent is for their foot. If they are really interested in activities that require a lot of uneven ground ambulation, and we try to do anatomic reconstruction because it allows the subtalar joint to work as normally as possible. This patient would heal with conservative treatment and would have essentially slight loss of height, slight difficulty with a wider foot because of the blowout, but probably their subtalar function would be reasonable, and they don't have much of the impingement of the anterolateral fragment into the sinus tarsi, which you see on a lot of the more dramatic dispressed injury. So in my hands, I would counsel her about the two options. One would be early range of motion, not weight bearing, versus open treatment, because that's the only way that I can reestablish all that morphology, and it's a discussion with the patient that you have to have.
And this patient actually was treated non-operatively. These are her 4-week follow-up images, and finally 8-week shots.
So you can see basically she was compliant because if you look at the height, it really is not appreciably different from the original injury, and most patients, if they're treated conservatively, have a hard time doing that because they end up inadvertently putting their foot down, and there essentially is insidious compression of the talus on the posterior facet, and that leads to more significant depression if you look at them later. But if they're able to be compliant, then potentially this would heal relatively quickly.
And then finally, one more case. It's a 54-year-old gentleman, fell 30 feet, closed right calcaneus fracture, otherwise healthy, non-smoking patient. Dr. San Giorgio, maybe you could click through these and give us your thoughts.
So it's a modest reduction of Bowler's angle, actually not, it probably would fall within the normal range if you measured it. The posterior facet follows all the way into the anterior process. There's some comminution that exits by the anterior facet, and the tuberosity itself is up. I'm going to guess that we have some coronals coming here. So on the coronal view, there's some widening. It actually extrudes a little bit medially. There is no subfibular impingement and no lateral extrusion, so there's room for the perineal tendons. The patient has a morphologic abnormality of the talus. This is consistent with a flat foot habitus. And there's some degree of impingement here, but I think there's still enough room for the perineal tendon. So this is another one that might be managed closed, although it's unstable because the dense ligaments supporting the medial side are obviously disrupted. So you might argue to treat this open based on that instability on the medial side.
And this patient was treated open by Dr. Benershka, so sir, maybe if you could just click through some of your fluoro shots.
Well, I think Bruce alluded to the biggest problem. If you go back, this is the biggest problem here. To establish a stability, remember we talked about the sustentacular fragment. This is what things have to anchor to, and essentially the posterior facet, although it's one large fragment, has been essentially translated laterally, and it's very difficult to get this reestablished unless you can compress the posterior facet to the sustentacular fragment, which is why this anterior process needs to be brought in. You can see it here, I think. This needs to be brought in to the sustentaculum, and that will afford the space for the remainder of the posterior facet to be brought in. And that essentially is what the big deformity is in this realm here rather than the tuberosity. The one caveat is if you look here on the axial projection, the varus of the tuberosity does not get better. It only gets worse over time. So you have to recognize that the tuberosity needs to be controlled. But really in this injury, it's this component of the injury that needs to be compressed to the sustentaculum, and this is what we did. This just shows you the intraoperative realignment of this large portion of the posterior facet to the sustentaculum, and then subsequently the area of compression. So this is really a relatively unusual injury because it's discontiguous with the entire posterior facet, but if you don't compress it, there's going to be difficulties with translation. As Bruce mentioned, the medial side is essentially subluxed medially, and so we reestablished the medial wall, and then this is just showing the fixation and then the compression. And when you look at the real key is on the lateral view. Now the anterior process is brought down to that sustentacular fragment. Posterior facet is anchored also to that fragment, and then the tuberosity is brought out of varus with that stiffness of the plate here at 6 weeks. Here you see the axial projection, so we're using the stiffness of the plate to control the tuberosity, and the clinical alignment at 5 months. That what you're trying to establish is that position of the heel when they strike the ground.